Manoria. He is a very well-known name in Bhopal and Central India. So people know him very well. So Dr. PC Manoria, he has done MBBS, MD Medicine, DM Cardiology, FACC, FESC and FICA. These are the degrees. He is currently the Senior Consultant Cardiologist and Director at Manoria Hospital, Bhopal, MP. Sir is the senior most interventional cardiologist of MP with the experience of more than 50 years. He is a former professor and head of cardiology department of Gandhi Medical College, Bhopal. He has held multiple positions. He was past chairman of Hypertension Council of Asia Pacific Society of Cardiology. He was past national president of Hypertension Society of India, past national president of API, past national president of CSI, past national president of Indian Society of Electrocardiology, and also Indian College of Physicians. Also, he was the past national president of Indian College of Cardiology. He was the past national president of Indian Academy of Clinical Medicines, past national president of Geriatric Society of India. So there are multiple things to his name. He has contributed in chapters to various books nationally, internationally, like API Textbook of Medicine, Epicon Update, PG Medicine, ICP publications, CSI, CME books, etc. for several years. And he is regularly organizing several national conferences since last 30 years. Recently organized World Congress of Cardiology in May 2022 at Mumbai. And also in 2023 also he has done a World Congress in Bhopal also. He has edited more than 30 books, more than 60 publications in various national and international journals.
Invite my esteemed colleague, Dr. PC Manoria, who is known for academic interest, and I'm sure along with the audience, I'll be benefited by his talk. I invite you, sir.
So, good evening, everybody. Slides are visible?
No, sir.
Now they are visible, sir. Now it's visible.
Visible. So, good evening, everybody. Before presenting a case of HFrEF, we are gathered here to rejoice the current science of HFrEF along with Dr. Rajiv Agrawala, particularly in the context of recent guidelines for heart failure, ESC 2021 and ACC 2022. So what has been the achievements of pharmacotherapy in heart failure? The first big achievement is that the 4 drugs have kicked off a new drug revolution in heart failure, which was never present before. And all these 4 foundational drugs, which all of us are aware of, they have a class 1 recommendation. They are categorized as guideline-directed medical therapy, and the beauty of all these 4 drugs is that they provide incremental benefit on top of each other. So you prescribe one drug, add another drug, there's incremental benefit. It continues till all the 4 drugs are on board. And the new way to initiate these drugs is quadruple initiation, if possible and feasible, maybe on the first day in lower doses. And here, as you can see, if you initiate all these 4 drugs, there is maximum benefit in terms of HF hospitalization or CV death, and maximum benefit in terms of all-cause death. A new dicta has appeared for heart failure. Just as in acute myocardial infarction, we have door to balloon time or door to device time. The current dicta for heart failure is door to GDMT time, which means how early you initiate guideline-directed medical therapy. And the second dicta is door to maximum dose GDMT, how early you maximize your therapy in patients with heart failure. This is very important because 1 out of 4 patients hospitalized for heart failure die or he is re-hospitalized within 30 days. and the 30-day mortality, all of us know in ADHF, is to the tune of 10%. The second big revolution which has occurred in pharmacotherapeutics of heart failure is so strong was the reverse remodeling with these drugs, particularly ARNI, that the committee members of the third universal definition of heart failure were forced to create a new subset of heart failure, that is heart failure with improved ejection fraction, which never existed before. And ARNI has very special contribution to this along with the other drugs. And the third big change which has occurred is that ARNI has transformed ICD eligible patients into ICD ineligible patients, and this is and some people call it ARNI as a medical ICD. I will like to have comments of Dr. Rajiv Agrawal also. And this is the data: 613 patients. At baseline, all patients had ejection fraction less than 35. All were eligible for ICD, but within a matter of 6 months, as you can see, as much as 32%, the ejection fraction increased to more than 35%. They become ineligible for ICD. And at the end of the year, as much as 61%, the ejection fraction increased to more than 35. So 61% patient became ineligible for ICD, and none of the patient died during this period. So the big dicta for ARNI is maximize and optimize the use of ARNI before ICD implantation. The fourth important revolutionary change which has occurred is that these foundational drugs are poised to postpone device therapy, be it ICD, CRT, LVAD, cardiac transplantation. In today's scenario, nobody would put these devices or cardiac transplantation unless you have maximized the use of all these foundational drugs along with the other drugs. And SGLT2 inhibitors in ARNI can be used across the spectrum of heart failure. So HFrEF, both of them have a class 1 recommendation. Mid-range, ARNI has 2B, SGL2A, and they can also be used in HFpEF. ARNI has 2B and SGLT2 2A recommendation, and improved ejection fraction, they are not discontinued, the 1B recommendation. And the other thing we must never forget is, while treating heart failure, target the cardiorenal continuum as a whole and never heart failure or kidney failure alone, because there's a very close connect between heart failure and kidney failure. Worsening heart failure worsens kidney failure, worsening kidney failure worsens heart failure. If you trigger benefit heart failure, it triggers benefit for CKD and vice versa. And this has been the other better understanding of heart failure, which means that up to an ejection fraction of 50 or 55, this is a neuroendocrine problem, which means neurohormonal activation plays a very important role. And all therapies for heart failure prior to 2016, they executed their action through neurohormonal modulation, so that we have 3 important blockers for the maladaptive neurohormonal system: the beta blockers, the ACE-ARBs, and the aldosterone antagonists. And later on we have the ARNI, which increases the activity of the vasculoprotective natriuretic peptide system. Once the ejection fraction crosses 50 or 55, neurohormonal modulation runs down and these drugs become ineffective. But SGLT2 inhibitors somehow is penetrated in HFpEF also, and other comorbidities like obesity, OSA, CKD, and so on come into scenario. And so in the present state of time, heart failure is not merely a neuroendocrine problem as was thought to be in the past, but it's a multifaceted syndrome, particularly when ejection fraction crosses 50 to 55. And the British Society of Echocardiography very rightly classifies ejection fraction normal as 50, because mildly reduced ejection fraction behaves in a similar fashion compared to the HFrEF. So below 50, all medications which work for HFrEF will also work for mildly reduced ejection fraction. And here you can see the same things, whether you are talking of the Paragon, Paradigm, Top Cat, Beta Blocker, or Charm, all of them cease to work once the ejection fraction crosses 50 to 55. So with these remarks, we will now have a case presentation. This is a 56-year-old male with the following symptoms. He presented with breathlessness and uneasiness for the last few days, difficulty in climbing stairs, not able to do his routine daily activity with the same ease as before, swelling on the feet and loss of appetites in the past few months, the usual story of heart failure. And on examination, he is conscious, afebrile, blood pressure 120 by 90, heart rate 120 per minute, respiratory rate 24 per minute, JBP elevated, first and second sound normal, LV third out sound heard, bilateral claps per abdomen, liver palpable, 4 centimeter below the costal margin, which is biventricular failure, CNS NAD, SpO2 92%. CPKMB 1.7 international, troponin 0.02, BNP markedly elevated, ECG, LVB, 2D echo, LALV dilated, severe LV systolic dysfunction, ejection fraction 20, no pericardial effusion clot, mild MR, mild TR, no PH, IVC dilated, and diminished response to the respiratory variation, and NT-proBNP you will see markedly elevated. Potassium levels, eGFR has not been mentioned. So the diagnosis was a recent ACS, non-STEMI, triple vessel disease and undergone an angioplasty and stenting to LAD. So the diagnosis is very obvious. This is an ischemic dilated cardiomyopathy, severe LV dysfunction and heart failure, HFrEF. And these are the drugs which the patient was on: aspirin plus prasugrel, antiplatelet, rosuvastatin as high intensity statin 40 milligram, and of the 4 foundational drugs we had Arni 50 milligram twice daily, carvedilol 3.25 milligram, torsemide 10 milligram, and SGLT2 inhibitors could also have been added, and pantoprazole. After 3 weeks, the vital parameters were normal, BP 110/70, kidney function test normal, medications was up titrated, hemodynamically became stable after 4 weeks, kidney function test normal, Arni was up titrated to 200 milligram, the maximum dose along with other medication, and follow-up was advised after 4 weeks. So patient improved symptomatically in terms of breathlessness and pedal edema, was able to walk for at least 30 minutes, do all his routine work with ease, and NT-proBNP improved to 650. And his current therapy was proton pump inhibitor, esomeprazole, DAPA, I think could have been initiated with 10 milligrams straight off. Rosuvastatin should be 40 here, although here it is mentioned 10 milligram, because high intensity statin is the treatment for secondary prevention. Epinephrine, Arni, carvedilol can be gradually up titrated, torsemide can be gradually de-escalated. So let's discuss. So this is obviously a case of ischemic dilated cardiomyopathy with HFrEF. And all of us know DCM affects the myocardium, is characterized by enlargement, dilatation of both the ventricles along with impaired contractility, and the ejection fraction drops to less than 20%. Here was less than 40%, here was 20%. Most cases of heart failure arising from DCM occurs from pump failure, and 70% due to dilatation. DCMP is one of the most common causes of heart failure we see in clinical practice. Prevalence 1 to 2050 to 400, up to 1 in 2,500 in the general population, and about 1/3 of heart failure patients labeled as idiopathic DCM. In most cases, DCM is progressive and leads to heart failure and death. So what is the role of medical therapy in heart failure with DCMP? Evidence back the use of sacubitril valsartan, and we have excellent reverse remodeling with Arni. So when we look at the data for Arni, although all 4 drugs are used along with it, look at the parameters of reverse remodeling. The left ventricular end diastolic volume decreased significantly. You can see the p-value top 0.02. The left ventricular end systolic volume decreased. You can see the value p is equal to 0.03. The left atrial volume index also decreased. And it also improved the ejection fraction by 5.3%. And it significantly improved NYHA functional class. You can see whether it is class 1, 2 or 3. And it also improved the 6 minutes walk test significantly. You can see sacubitril valsartan improved 6-minute walk test by 86 meter in HFrEF patient with DCM. The beauty of ARNI or sacubitril valsartan is it is a pan-mortality drug, which means whether you are talking of an all-cause mortality, it decreases by around 16%, cardiovascular mortality 20%, and sudden cardiac death is also decreased by 20%, and mortality due to worsening heart failure is also decreased by 21%. So it decreases mortality across the board. And another interesting feature is that if the patient is on ICD, if the patient is a non-ICD, it also benefits. But if the patient on ICD, you can see a 16% reduction in the risk of cardiovascular death or hospitalization with sacubitril valsartan. What is the importance of titrating to the optimum dose? While treating HFrEF, all therapies should be escalated to target dose unless side effects preclude their dose. De-escalation should never be attempted because heart failure is never stable and is potentially dangerous. Every effort should be made by the clinician to achieve and maintain the clinical trial defined target doses of the guidelines, whether the ACC 2022 or ESC 2001. So in patients with HFrEF, titration of DDTMT dosing to achieve the target dose should be efficacious in the RCT recommended dosage to reduce the cardiovascular mortality, HF hospitalization unless not well tolerated. And ARNI, when it decreases hospitalization, this is indeed a great achievement because every hospitalization, every rehospitalization takes the patient closer to death. So if you somehow can decrease hospitalization, this is indeed a great achievement and produces great benefits in the cost of the treatment of patient. In patient with HFrEF, titration and optimization of GTE, particularly ARNI, beta blockers and all other drugs, 4 drugs, should be done at the earliest 1 to 4 weeks, preferably before discharge, otherwise not later than 4 weeks. Even if symptoms improved, I think de-escalation should not be attempted because heart failure is never stable and potential danger. If the target doses cannot be achieved, utilize the maximally targeted dose, maximally tolerated dose. And the ESC also medication should be titrated to doses used in clinical trials. The other thing which should also be addressed is the physician inertia should be minimized. The patient and family must be motivated for long-term polypharmacy to improve the outcome, just as we do in treatment of cancer patients. What are the implications of up-titration of doses of ARNI to the target dose? Here you can see if you up-titrate to the conventional maximum dose, 200 milligram twice daily, there's impact on the all-cause mortality. You can see on the left side of the screen, 18.18 and 6 months. There's also impact on the HF hospitalization. You can see on the right side of it. So try to optimize the dose if possible and feasible unless side effects preclude. And this shows the effect on ejection fraction. ARNI is powered to increase ejection fraction to a great extent, and we have seen patients who are in grade 4. There is tremendous improvement and they are doing their daily activities because of excellent reverse remodeling. So the management of DCM and HFrEF has undergone a revolutionary change. It has also postponed device therapy, cardiac transplantation. The prognosis of DCM patient has significantly improved during the last decades due to excellent and revolutionary 4 foundational drugs. The survival along with no need to heart transplant has risen to more than 80% 8 years follow-up. About 15% of patients of dilated cardiomyopathy show normalization of their LV size and function after sufficient medical treatment, particularly Tokushobo cardiomyopathy, some patients postpartum, or some patients DCM following myocarditis. So ESC 2021 guidelines recommend sacubitril/valsartan as the first line therapy instead of ACE and all half-ref patient, and use of sacubitril/valsartan is recommended as a replacement for ACEI in suitable patients who remain symptomatic on ACEI, beta blocker MRA therapies. However, sacubitril/valsartan may be considered as a first line instead of ACEI. Even the recent ACC 22 guidelines are recommended as first line therapy, but all four foundational drugs should be used. And in chronic symptomatic HFrEF class 2-3 who tolerate ACE or ARB, replacement ARNI is recommended. ARNI is also recommended as a de novo treatment in hospitalized patient with acute HFrEF before discharge. Despite advance in heart failure, the big problem is 75% of heart failure do not get the optimal GDM. This is one of the important cause of increased morbidity and mortality. We must try to bring larger number of patients under the net of these four foundational drugs. And therefore, we can have charts in the hospital and before discharge to see that every drug has been used which is required for the patient. And there are also tools for initiating guideline directed medical by the American College of Cardiology. There are also apps which you can download to optimize the therapy. So the big message is in HFrEF patient with DCM, just an acute myocardial infarction, time is muscle. In HFrEF also, time is essential. All four drugs, if possible and feasible, should be initiated right on the first day, maybe in lower doses, and try to maximize the dose if possible and feasible before discharge, otherwise within 1 to 4 weeks. And all these four drugs improve the NYHA functional class, 6-minute walk test, quality of life. The RNA produces excellent reverse remodeling as shown by ecoparameter. It reduces the risk of cardiovascular death or hospitalization, and RNA is superior to ACI in all subset of patients. So I think thank you very much, and over to Dr. Rajiv Agrawal. Dr. Rajiv, I would like to ask one clarification from you. Hello?
Yes, sir.
A patient had ejection fraction less than 35. He was given an ICD. His ejection fraction has increased to 40 or 42. His battery is going to get depleted. Will you change the battery, or will you continue ICD, or will not recommend for continuation of ICD?
So this is a difficult question and cannot be answered because guidelines do not recommend that way. Guidelines have not extended the evidence in terms of electrical therapy. They say de novo, they may need not, but there is no guideline recommendation, so it will be a very good medical legal responsibility of a clinician to remove ICD, and not to remove, not to change the battery. So I will say there is an evidence, but no guideline direction. We have to change the battery. That is how I look at it. But your point is very valid.
The second issue is in cardio-oncology, people are still not using ARNI, they are still using beta blockers and AC inhibitors. I think although there is no trial, but this does not prevent them from using ARNI because the subset is HFrEF. Your comments, please.
Yes, yeah, I fully agree. There is a very recent article, off-label uses of ARNI. And there they have shown hypertensive who are uncontrolled in HFpEF. They can be used tubo, peripartum cardiomyopathy, refractory hypertension, obstructive sleep apnea, hypertension. All these patients are off-label use of ARNI, and I agree with you, this is a drug of organ failure. This is not specific to any disease. This is not anti-amyloid therapy that it will work only in amyloid heart disease. This is an organ failure drug, and irrespective of the cause, it should be used, and you should know there are two aspects. This is all four foundation pillars. Don't forget to find the cause of cardiomyopathy. That always remains the issue.
Up to what level of EGFR do you use ARNI? Means after how much level below 30?
The guidelines are it can be used even in dialysis patient. I have a paper just in front of me which talks about
Absolutely,
two
boss.
newer indications. Two indications. One, there is a study which talked about patients on dialysis and peritoneal dialysis. Given ARNI, they have shown that the LV improves. It may not protect the kidney, but at the same time, it protects the heart. It is not nephrotoxic for that matter. It is not nephrotoxic. So it can be used. The another usage of ARNI is congenital heart disease where systemic pressures are there in right ventricle. You can still use ARNIs in that situation. The third information which has come very late now that when you treat these patients in HFrEF, not only the left ventricle improve, the right ventricular hemodynamics and TAPSE, they all improve. And they go hand in hand because there is ventricular remodeling of the whole heart. So the advantage of harnies are not limited to left ventricle, they extend to right ventricle. So once again, I feel whenever there is an organ failure, use it. And bad renal failure, even up to dialysis, there is not a guideline recommendation. Once again, I'll club them as off level use and just watch it. If the patient is tolerating it, it may not give you renal protection, but it will give you definitely the cardio protection.
The
Yes,
usual
Rajiv boss. Very
data
good
when
evening.
we discuss it with the nephrologist, if the reduction in GFR is not more than 30%, you can use up to any level of GFR. Although you have to be cautious in terms of hyperkalemia and other parameters.
Yes, and blood pressure.
Yes, yes, yes.
So,
No,
Rajiv boss, that
there
was
are studies on dialysis. There are studies on dialysis patients. They have
yeah,
shown that their hemodynamics and ventricular remodeling it changes, and it looks logical. If the renal function patient is on dialysis, what harm it can do?
absolutely, absolutely. So that was my question, Rajiv boss, regarding the stage 4 and stage 5 CKD patients. Like recent study is showing that this is safe drug, considering, as Dr. Manoria said, that hyperkalemia and pressure health should be monitored very closely, and kidney function should be monitored closely. We can use this in stage 4 and stage 5 even of CKD.
The issue is in general practice, whenever we prescribe ARNI, EGFR, maybe in stage 4 kidney, most of them they cut off some of the nephrologists, which is not wrong because patient has heart failure inevitably. He will die of heart failure earlier than the kidney problems.
Kidney
So
problems,
ideally it
absolutely.
should be used, but many times we have seen it is stopped the moment they see creatinine above 2 or 2.5 or EGFR dropping to less than 30 or, but should be used because heart failure is inevitable with CKD.
So
Yes, boss.
there is a question in chat box, sir. Can ARNI be started in HFpEF? So
Yes.
I will say the FDA approval for HFpEF is in terms of risk reduction in heart failure, no mortality benefit, and one should not forget the Paragon was a negative trial. So I'm not saying Paragon HFpEF trial was positive. It was a negative trial, but in HFpEF patient, the first drug of choice is SGLT2 inhibitors. Then comes class 2B drugs,
MRA.
both ARNI and MRAs. They can be used together for risk reduction in HFpEF patient of hospitalization, no mortality. There is another question which is very interesting. Looking to the benefits of ARNI in reverse remodeling, can we initiate Vimada in post-MI patient also for preventing further risk of sudden cardiac death? So, Dr. Manoria, what is your take on Paradise AMI? Because that question relates to Paradise AMI.
Absolutely.
After some time, the definite time has not been defined by any trials. RD can certainly be used. It may be not superior in the early phase of myocardial infarction as was shown by the Paradise AMI trial, but after sufficient length of time, or particularly if your ejection fraction is not improving, the parameters for reverse rounding are not improving, you can certainly switch to ARNI instead of an AC inhibitor. And of AC inhibitor, ARNI has definitely shown reduction in sudden cardiac death, almost to the tune of 20% in the paradigm HF trial. Trials of AMI are not available.
So boss, we can say it wherever there is a chances of neurohormonal activation, we can bring RNA there, and surely it will benefit, isn't it, boss? Whether it's
You
OSA,
see, as
OMI.
the Paradise AMI
Yeah.
was a very neutral trial, is not a negative trial, is a neutral trial in terms of there was no superiority.
Yeah.
It was non-inferior. Arni was not non-inferior, so it does not mean that you can't use it. But de novo acute heart failure, Arni has got a controversial guideline status, but chronic heart failure with acute decompensation, yes, you can use it. So that part is very well defined. A HFrEF patient coming to you with acute worsening, you can use ARNIs, but first time acute heart failure following acute MI, there is no superiority. There is no superiority on ASARB. So it can be used, but there is no superiority. Dr. Manoria, do you agree with this kind
Yes,
of?
yes, yes.
Uh, Absolutely, boss. That ejection fraction can recover after some time in these acute MI patients, which may be in the early phase, earlier in the heart failure phase, isn't it, boss?
No, we have not shown the limited follow-up. We have not shown the benefit. That is what I'm saying, that in acute heart failure, acute ischemic heart failure, de novo, today is not a superior indication. They are at part. So why use a costly drug? That is the way we look at it. And if the heart failure is bad, it is not responding, maybe ARNI can come in, as Dr. Manoria said. But this is a vague area which is not cleared by guidelines. So, any more questions?
Thank you, boss. Thank you very much.
Sir, I don't think there are any more questions neither in the chat box nor from doctors. So I would like to thanks Dr. Manoria sir and Dr. Rajiv sir for sparing their time for the Novartis event. Thanks a lot, sir. Have a wonderful weekend ahead, sir. Happy New Year in advance
Thank you,
to
sir.
both of you. Thank you,
Thank
sir.
you, sir. Thank you so much.
Thank you. Thank you. Wish you all very happy. Thank you. Wish you all.
Merry Christmas and Happy New
Thank
Year,
you.
sir. Thank you. Thank you all.
Good night.
Good night.
Good night, sir.
Thank you, sir. Good night, sir.